Welcome to the Step 1 primer video on sympathetic inhibition, our fourth and final video on autonomic pharmacology. We hope you enjoy it.
Welcome to Pharm Basics 4. Let's go through the warm-up. First question, what structures are derived from the branchial pouches? So the first branchial pouch is where we get the mastoid air cells, the middle ear cavity, and the eustachian tubes. The second branchial pouch is the lining of the tonsils. The third pouch is the thymus and also the inferior parathyroid glands. And then the fourth pouch is the superior parathyroid glands. Next, what structures run through the cavernous sinus? So you have the oculomotor nerve, which is cranial nerve 3, the trochlear nerve, which is cranial nerve 4, the abducens nerve, which is cranial nerve 6, the ophthalmic nerve, which is the first division of the trigeminal nerve, the maxillary nerve, which is the second division of the trigeminal nerve, and also the internal carotid artery. And the last question, what are the clinical features of osteogenesis imperfecta? So osteogenesis, you're going to think about brittle bones, and that leads to multiple fractures. You can see those blue sclerae. You can have dental problems and also hearing loss. So that's it for now. Let's move on to the lecture.
Hello everyone, and welcome to another episode of the late night talk show, Lols! And here's the star of our show, Dr. Lewis! Thank you everyone. Welcome to another Step 1 lecture. Why are you all laughing? I don't get it. I need my intro for this lecture. I was way too drunk. Tired last night from studying. Oh, you guys read the script wrong. This lecture is about beta blockers. It's OLOLs, not LOLs. I hate LOLs. Beta blockers end in OLOL, OLOL. Now this all makes sense. All right, well, I guess since I'm here, I'll do a little comedy. Don't you just hate people who say lol? Okay, touchy, move on. Okay, so guys, in the last lecture we talked about sympathetic activation. Now let's do a super rapid review. So in that sympathetic nervous system, we have very short preganglionic fibers stimulating those nicotinic receptors on ganglions that are very close to the spine, and then very long postganglionic fibers that secrete norepinephrine that stimulate adrenergic receptors at the effector organs. Now, remember those four important adrenergic receptors: alpha 1, alpha 2, beta 1, beta 2. Remember that alpha 1 is causing an increase in peripheral resistance, increased bladder sphincter tone as well. Alpha 2, remember, it inhibited norepinephrine release on the presynaptic neuron. Beta 1 increases heart rate and contractility. Beta 2 causes mild vasodilation and, more importantly, bronchodilation. Now, the drugs we talked about vary depending on the effect on each one of those receptors that are found on those different concentrations throughout the entire body. So now we're going to inhibit the sympathetic nervous system. And just like the mimetic drugs, these drugs will act depending on their effect on the specific adrenergic receptor. And we even refer to them as such. So there are alpha blockers, there are beta blockers, and a couple others that really don't fit into those categories exactly. So the first thing we're going to talk about are the alpha blockers. So remember that alpha 1 receptors maintain our vascular resistance and also some urinary sphincter bladder tone as well. So if you block them, then we should expect a decrease in blood pressure and a relaxation of the bladder sphincter tone. Now, alpha 2 receptors tend to decrease norepinephrine release, and the alpha blockers in general are divided into drugs that are non-selective, meaning that they block both alpha 1 and alpha 2 receptors, and then selective agents that only block alpha 1. Now, the more commonly used medications are the selective blockers, and they include drugs like prazosin, doxazosin, terazosin. And since they block alpha 1, they tend to decrease blood pressure. Now, clinically, probably they're used more often for their effect on bladder sphincter relaxation. Specifically, they're used in men with benign prostatic hyperplasia, or BPH. Now, their side effects include postural hypotension. So when they stand up, they tend to drop their blood pressure. And that certainly makes sense because these drugs will reduce peripheral resistance. Also, you'll see some reflex tachycardia as well. Again, that makes sense because when your body senses lower peripheral resistance, it tends to react by increasing the heart rate. Rebound hypertension is also a concern when you stop these medications abruptly. Now, there's one other alpha 1 selective drug that I want you to know about, and it's tamsulosin. So tamsulosin is an alpha 1 antagonist used to treat BPH, and it's inhibiting the smooth muscle contraction in that bladder. So it's just like your Zosyn drugs. But this one is even more selective. It's selective for what's called an alpha 1AD receptor, which is found really just in the prostate. So it relaxes that smooth muscle in the prostatic region and that urethral smooth muscle so that urine can pass more easily. It does not relax the vascular vascular 1B receptors. That's what you're going to find in your vasculature. So tamsulosin is not going to lower your blood pressure near as much as the typical alpha-1 blocker. So patients with BPH with high blood pressure, maybe you go with a Zosyn drug. If they don't have high blood pressure, go with tamsulosin. Now, the non-selective alpha blockers are not used clinically all that often. Phenoxybenzamine and phentolamine are used in the diagnosis and temporary treatment of things like pheochromocytoma. Now, since we don't see that very often, we don't have much use for these medications. Now, one of the reasons we use phenoxybenzamine is because it irreversibly binds to the alpha-1 receptor, and even very, very high levels of catecholamines are unable to stimulate those alpha-1 receptors that you might see in pheochromocytoma. All right, so the next class of sympathetic inhibitors are the beta blockers, and we use these all the time. And again, we have a few subgroups depending on which receptors that we're inhibiting. First, we have the non-selective beta blockers, which, as you can probably guess, block both beta 1 and beta 2 receptors. And these drugs include propranolol, timolol, and nadolol. Now, the beta 1 selective drugs include drugs like metoprolol, atenolol, and esmolol. And there actually aren't any really clinically usable just beta 2 selective drugs. So when we talk about a selective drug for the beta blockers, it's just a beta 1. Now, we have two kind of unusual beta blockers called acebutolol and pindolol. So they're actually very weak agonists at the beta 1 and the beta 2. But because they are so weak, they actually act as blockers because they're blocking the much more potent effect that epinephrine or norepinephrine would have on those very same receptors. You would consider using these drugs in patients who have hypertension and bradycardia because these don't actually affect the decrease in heart rate as much as some of the other beta blockers. And then finally, we have these hybrid drugs. These are the alpha-beta blockers, and they include things like carvedilol and labetalol. They block at alpha-1 and beta-1, so you get the regular beta blocker effect, but you also get some peripheral vasodilation as well. Now, beta blockers are used quite often to treat a lot of different things. Specifically, hypertension is probably the biggest one. Also, by blocking beta-1 receptors, you slow the heart. You can decrease the contractility and thus decrease the overall work of the heart, which is highly favorable with patients with things like coronary artery disease. So you'll see a lot of these drugs being used with patients with angina, patients who have had a heart attack. Beta blockers can also slow the progression of congestive heart failure, but you have to be careful in patients in a CHF exacerbation. Those patients are not pumping very well, and they have things like pulmonary edema and lots of problems. So slowing the heart may actually make the situation worse. So sometimes you have to take people off their beta blockers if they're in exacerbation. Now, less commonly, beta blockers are used to treat patients with symptomatic hyperthyroidism or very, very rarely the serious thyroid storm. Sometimes we use them for migraine, headache prophylaxis, or even for anxiety. I have patients who use propranolol when they have to give a speech in front of a large group of people. So we established that by blocking beta-1, we decrease the heart rate. And now this is achieved by slowing down the SA and the AV nodes. So you can use this in patients with supraventricular tachycardia as well. However, it also becomes a major side effect as well. When prescribing these medications, you can certainly cause things like bradycardia, which can lead to lightheadedness and even syncope. One not so obvious clinical usage of beta blockers is in glaucoma. Beta blockers, when used topically like, say, timolol, can actually decrease the production of aqueous humor and improve the situation of glaucoma. Another use for beta blockers is aortic dissection. So beta blockers are the antihypertensive drug of choice in patients with aortic dissection. So in aortic dissection, the high blood pressure is causing a dissection or a tearing between the two layers of the aorta. So you need to lower the blood pressure first to prevent this from getting worse. But you don't just reach for any drug. You typically reach for that beta blocker because beta blockers not only decrease the blood pressure, they decrease the slope of the rise of the blood pressure. So it's not just the high blood pressure that's making that aortic dissection worse, it's that rapid increase of BP during each beat of the heart. So that's why beta blockers are the antihypertensive drug of choice for aortic dissection. Now, what are the effects of blocking the beta-2 receptors? So if you're using maybe a non-selective beta blocker, you're blocking beta-2, which can lead to bronchoconstriction. So you definitely want to avoid these beta blockers in patients who have asthma and those who have COPD. The selective beta-1 blockers are better, but still you need to be a little bit careful when using those drugs even in this population as well. Now let's talk about some more adverse reaction with beta blockers, pretty high yield stuff. Beta blockers can decrease glycogenolysis and glucagon release. So therefore, diabetic patients on anti-diabetic medication may be at a little bit higher risk of hypoglycemia. I personally don't see this very often, but you might see that on your test. Probably more importantly, though, is that beta blockers prevent many of the symptoms associated with hypoglycemia. So when a patient gets hypoglycemic, they get shaky, they get tachycardic, they get really sweaty. But beta blockers prevent this from happening. Therefore, patients can even get more hypoglycemic and not even know it. Now, another point I want to make about the beta blockers is when dealing with cocaine. So if you have a patient who comes in with a cocaine overdose or who is really intoxicated on cocaine, they're having a lot of tachycardia, a lot of hypertension, you might want to give them maybe like a beta blocker to bring that blood pressure down, right? Well, the answer is no. We don't want to give these patients who are on cocaine a beta blocker. So why is that? Well, cocaine is going to cause stimulation of all the adrenergic receptors. Not directly, but indirectly. Remember from our last lecture, it's going to reduce the uptake of all those catecholamines. So all of these are going to be acting on all the adrenergic receptors. Remember, alpha-1, alpha-2, beta-1, beta-2. And remember, sometimes that beta-2 is going to actually cause some vasodilation. And that's going to help kind of temper the hypertensive response of a cocaine intoxication. So if you give a patient cocaine, that's going to stimulate alpha-1, and that's going to raise their blood pressure, but it's also going to be stimulating beta-2, and that's going to help reduce that blood pressure just a little bit. Well, say you give that same patient a beta blocker. It's blocking the beta-1, it's blocking the beta-2 response, and all you have left is what we call an unopposed alpha-1. So you may have an actual increase in your blood pressure when you give a beta blocker to patients who are already on cocaine. Instead, we use things like benzodiazepines to calm them down. You might even use something like phentolamine, which is an alpha blocker that we talked about before, and that's going to decrease that sympathetic stimulation. Now, another potential problem is if you abruptly stop a beta blocker. You can actually get a rebound tachycardia, maybe a rebound hypertension, and even an arrhythmia in susceptible patients. You may have heard that beta blockers cause erectile dysfunction. You hear about that all the time. Now, recent studies actually haven't really found this to be the case. Also, let's think about that. What controls erection? Remember the mnemonic point and shoot. So erection is initiated by the parasympathetic nervous system. So how can we inhibit an erection by inhibiting a receptor in the sympathetic nervous system? Well, you probably can't. Now, some studies have guessed that this may be a placebo effect because men have been told for years and years beta blockers can cause ED, and once you start thinking about it, well, then it kind of happens. Okay, guys, so you better know your OLOLs by now. Let's see if you know which category goes with each beta blocker. All right, everybody, welcome to another Lewis Notes. Today we're talking about beta blockers, and you need to know where all these beta blockers are going in regards to category. So, because there's a big difference between a non-selective beta blocker, a selective beta-1, a partial, and alpha beta, and then I threw in here glaucoma drug, so you can remember that all of these are oral, some of them are eye drops. So the first one here is metoprolol. We use metoprolol all the time. It is a very commonly used selective beta-1 blocker. Atenolol, also a selective beta-1 blocker. Propranolol, not used as much, but still I use it here and there, and it's a non-selective beta blocker. You got to be careful because it might cause some bronchoconstriction. Timolol, I put twice here because not only is it a non-selective beta blocker, but we use this for glaucoma. And then acebutolol is one of those funky ones. It's one of those partial agonists. Remember, it's very, very weak. So even though it's stimulating that receptor, it's blocking it enough that it's not near as powerful, say, norepinephrine binding to it. Carvedilol is one of those alpha blockers. You're getting alpha-1 and beta-1 control there. Nadolol is also a non-selective beta blocker, and it's going down here to glaucoma drugs as well. Pendolol is another one of those weird partial agonists, and that's one of those situations where you might want to control blood pressure, but you don't want to drop the heart rate very much. And labetalol is another one of these cool alpha-beta blockers. So if you can kind of get all those together and figuring out where they are, then you can do a lot of lols. So hope you learned something. That's it. So next I want to talk about two drugs that are not antagonists like our previous medication. They're actually agonists. And more specifically, they are alpha-2 agonists. Now remember that alpha-2 receptors are located on the presynaptic neuron, and they act to inhibit norepinephrine release from that same neuron. Now the two medications are clonidine and alpha-methyldopa. Now we covered clonidine in the last lecture because that's when we had all of our agonists. Now overall these medications are acting centrally and are decreasing sympathetic tone. So remember, they decrease the release of norepinephrine from the presynaptic neuron. Clonidine can be used in an outpatient setting when a patient is having a malignant hypertension. So you can give them clonidine orally in the clinic and it will actually work relatively quickly. I generally don't like doing this very often unless things are really bad, because one of the unfortunate side effects of these medications is rebound hypertension. So you may have improved the BP in the office, but a few hours later that BP may go even higher when they get it home. Clonidine is sometimes used as a sedative, and again that makes sense because it's decreasing the overall sympathetic tone of the body. Methyldopa is not used very often for hypertension in general, but it's still sometimes used in pregnancy-induced hypertension. Okay guys, that's going to be it for the lecture part. Now it's time for that end of session quiz. Let's go through these answers together. First question here, which selective alpha blocker has less effect on blood pressure? Remember, that's going to be tamsulosin. Next, what are the common side effects of beta blockers, and which patient population should use caution when taking beta blockers? So, some of the common side effects. First one, we have bronchospasm, especially with those non-selective beta blockers. You never want to use a non-selective beta blocker in a patient with asthma or COPD, and in general, just use caution with even the selective beta blockers as well. Beta blockers can lower blood glucose and they can mask the sympathetic symptoms of hypoglycemia. So you need to use caution when you're giving a beta blocker to a diabetic. And then they can also cause bradycardia and even an AV block. They can depress myocardial contractility, so you want to use caution in giving beta blockers to patients with really bad or uncontrolled CHF, especially in an acute exacerbation. Next, what are the various clinical applications of beta blockers? So beta blockers can be used for a lot of different things that we've gone over, primarily hypertension, but you can also use it for CHF, supraventricular tachycardia, angina, MI, and some beta blockers are used for glaucoma as well. And finally here we have a couple rapid fire facts here. Pheochromocytoma is an alpha antagonist. BPH, selective alpha blocker, like we said before, go with tamsulosin. All right guys, so that's going to be it for Pharm Basics 4. I hope you learned something. See you next time.